Hello, my name is Meghan Michele. I'm a medical social worker in the geriatrics department in the Petaluma Clinic. Before we start class today, I'm going to review Kaiser's group class confidentiality agreement, and it states that privacy is a concern for everyone in a group class. Each participant wants what is said in the group to be treated with respect and complete discretion. Along with Kaiser Permanente's commitment to foster respect for all in the class, each participant also has a responsibility to respect and protect each other's privacy. So please share useful general information outside of the group, but what you hear and learn about individual group members should stay here. So the class that I'm teaching today is evaluation of memory or cognition. In today's class, we're going to discuss cognition and the normal age-related changes in cognition. We're going to talk about other conditions that can cause cognitive changes. And we're going to talk about how we make the diagnosis, the different causes and types of dementia, the natural history and complications of dementia, and how dementia is managed. So cognition is much more than memory. Cognition is thinking skills, including memory, language use, calculation, perception, awareness, reasoning, judgment, learning, intellect, social skills, and imagination. There are quite a few typical age-related changes in cognition. My favorite is increased wisdom. We also experience reduced perception, so it can be harder for us to see or hear. We also have a shorter attention span, which is one of the reasons why I try to keep this class to less than an hour rather than 2 hours. We also have a greater sensitivity to interruption. It can become more difficult for us to multitask, so it's easier for us to focus on one thing at a time rather than two. Our ability to process incoming information slows down, which is a good reminder for me to try to speak slowly during today's class. And creating new memories and retrieving old memories can be more difficult. There are quite a few medical conditions that cause cognitive changes. This is not a complete list by any means, and I'm going to let you go over this on your own at a later time. But the takeaway from this slide is that the geriatrician may ask you to complete some labs before you come in for your assessment. And it's really important that you do that because the geriatrician wants to rule out other reasons or causes for the symptoms that you're experiencing. There are a few psychiatric conditions that can cause cognitive changes. One of them is depression. Depression used to be called pseudo-dementia, and that's because people that experience depression can have a hard time focusing. They're often less motivated, and their memory can be impacted. Also, anxiety can cause cognitive changes, as well as stress. Of course, abusing things such as alcohol, marijuana, and other drugs can cause cognitive changes. And suffering a traumatic brain injury, or TBI, can also cause cognitive changes. So dementia, or major neurocognitive disorder, is evidence of significant cognitive decline from a previous level of performance in one or more cognitive domains, such as complex attention, executive function, learning and memory, language, perceptual motor, or social cognition. And this is based on concern of individual. So what it is that you are noticing, the changes that you're observing. It's also based on a knowledgeable informant's report. So what the caregiver or the family member is seeing. And it's also based on the clinician's assessment. It's based on a substantial impairment in cognitive performance, preferably documented by standardized quantified clinical assessment. And the cognitive deficits interfere with independence in everyday activities. And we're going to discuss this more later on. That part's really important. The cognitive deficits do not occur exclusively in the context of delirium. And I'm also going to explain what delirium is as well. The cognitive deficits are not better explained by another medical condition. So for example, it would not be the depression that's causing the cognitive changes. So in making the diagnosis, the geriatrician considers the patient as a whole. And that means that they want to consider how you're doing in the home and in the community on a daily basis. So when doing this, they're going to do a very thorough history. Before you come in, you're going to be given a pre-visit questionnaire. We ask that you complete this before your assessment. And this pre-visit questionnaire asks a lot of information about how you're doing at home and in the community on a daily basis with such as activities such as paying bills, things like that. We also ask that you bring in all of your medications, including the prescribed medications, over-the-counter medications such as your vitamins, sleep aids, supplements, anything you're taking, please bring in. We also ask, as I mentioned before, to complete your labs and maybe some brain imaging too before you come in. And this is really important because, as I said before, the geriatrician wants to rule out other reasons as to why you're experiencing the symptoms that you're having. The clinician's examination is going to assess physical, neurological, and mental status. So what I mean by this is that they're going to be asking you a lot of questions and they're going to ask you to look at some things as well. So it's really important for you to bring in your hearing aids and your glasses. Even if you absolutely hate them, even if you're not using them at home, please bring them in anyway. They're also going to complete a cognitive screening. It might be the Montreal Cognitive Assessment, the MOCA, or the St. Louis University Mental Status, which is the SLUMS. So in doing the cognitive history, they're going to be asking you some memory questions, such as, have you been losing keys or other items? They're also going to ask you some language questions. Have you been having trouble getting your words across? And they're going to discuss geographic orientation. They want to know, have you been getting lost in familiar neighborhoods? They're also going to complete a functional assessment. And as I said before, this is also addressed in that pre-visit questionnaire that we want you to complete before your assessment. So they want to know how you're doing with, say, using the phone. Has it become more challenging for you to call up family members and friends? Also, how are you doing with your shopping? Are you doing this independently or is someone doing your shopping for you? We also want to know how it's going with cooking and meal prep. Have there been times where you've left the stove or the oven on? We also want to know how you're doing with your housekeeping and your laundry. Also, we want to discuss how you're doing with taking your medications. Are you taking them on time and appropriately and as prescribed? Also, how are you doing handling your finances? Have there been times where you've paid a bill late or two? Also, maybe somebody's writing checks for you and you're just signing your name on the checks. We also want to discuss how you're handling your chores and your home repairs. And we also want to discuss how transportation and driving is going. There are quite a few factors that are considered during the assessment. One of them is your age. We also want to know about the highest level of education you completed. And we also want to consider your cultural background. And one of the reasons for this is on the Montreal Cognitive Assessment, you'll be asked to identify 3 different animals. Now there's a chance, based on where you grew up, that maybe you've never seen those animals before. So again, it's important that we know your cultural background. Also, we want to consider the fact that you might be experiencing some anxiety. And if you are experiencing some anxiety, this can impact your test performance. We also want to consider your baseline function versus change. What I mean by this is that maybe you've always had somebody coming in and doing your house cleaning, or maybe you've always had somebody writing out your checks for you. So that would not be a change. We also want to consider your sensory function. So as I said before, maybe it's hard for you to hear or see. And we also want to consider the fact that what you're experiencing might just be normal brain aging. So when you're in the clinic, the geriatrician might show you this stop sign. Green is healthy, normal aging, healthy brain. Yellow is MCI, or mild cognitive impairment. And that's not healthy or normal aging, but it's also not dementia. And we'll talk about that in the upcoming slides. And red is disabled, because dementia is a disabling disease. So as I said, mild cognitive impairment is not dementia. The main concern with mild cognitive impairment is memory loss. And the cognitive screening would show that memory loss and some other cognitive impairment, like with your thinking skills. And generally, people that have mild cognitive impairment are doing just fine in daily life. So what I mean by this is maybe they're, paying their bills without any problems, shopping without any problems, cooking on their own. As I said, the main concern with mild cognitive impairment is memory loss. Also, delirium is not dementia. Delirium is an onset of sudden confusion or change in mood or behavior caused by a medical condition. So it may be caused by medications or an infection, such as a urinary tract infection or UTI. Delirium usually resolves once the medical condition is treated, though it could last up to 3 months. Dementia, or major neurocognitive disorder, is not just part of getting older, but age is the biggest risk factor for developing dementia. For those that are 85 and older, there's about a 50% chance that they might develop dementia. Dementia is a brain disease that is progressive and it is irreversible. It does not mean that an individual is crazy, and I want to emphasize this because I oftentimes have family members and caregivers come to me and say that their loved one is acting insane or crazy. And it's important to recognize that the symptoms that you're seeing and the behaviors that you're seeing and the cognitive changes that you're seeing, that's not the person, that's the disease. We want to separate the disease from the person. Also, dementia is an umbrella term. There are several different causes and types of dementia, so let's discuss some of those now. The first one is Alzheimer's disease. I'm sure most of you have heard about this one before. Alzheimer's disease accounts for about 60 to 70% of the types of dementias that are diagnosed. There's also vascular dementia, which accounts for about 20 to 30% of the dementias that are diagnosed, And more we're seeing mixed dementia. And mixed dementia is overlapping Alzheimer's disease and vascular pathology. And it's likely the most common, especially in the oldest of the old. Other dementias include Parkinson's disease, frontotemporal dementia, dementia with Lewy bodies, and there are other less common causes. And those dementias account for about 10% of the dementias that are diagnosed. Alzheimer's disease. As you can see in this picture here, there's a normal brain, and then next to it is the Alzheimer's brain, which is shrinking. So people with Alzheimer's disease experience memory loss, language disturbance. They have an impaired ability to reason and handle complex tasks. They experience changes in personality or character, and they're usually less motivated. And the doctor finds no neurological problem. With vascular dementia, patients experience an abrupt onset of neurological problems. They might have some slurring, or like the man in this picture, they might have weakness on one side of their body. And this is due to decreased blood flow to the brain, such as a stroke. The theme with vascular dementia is that people experience a stepwise deterioration. And what I mean by this is that with each stroke they experience, the further decline they will have. Stroke risk factors include high blood pressure, diabetes, and high cholesterol. Dementia with Lewy bodies. So in this picture here, you can see that the man is looking at flying elephants and a creepy cat on the end of his bed. So people that have dementia with Lewy bodies experience visual hallucinations or delusions. So either they see things that are not there or they believe things that are not real. They also experience a fluctuating cognition. In fact, dementia with Lewy bodies can sometimes look a lot like delirium. They also have Parkinson-like motor symptoms, so they may have a tremor or difficulty walking. But the thing with dementia with Lewy bodies is that they have the cognitive changes before those physical symptoms, before the Parkinson-like motor symptoms. Also, people with dementia with Lewy bodies are sensitive to antipsychotic medications. So if they take antipsychotic medications, they may get worse, or their symptoms may get worse. Frontotemporal dementia. I really like this image here because it paints a good picture of what frontotemporal dementia can look like. And that's because you would never expect an elderly man to hop on a kid's ride at the local mall and pretend to be shooting fellow shoppers. So people that have frontotemporal dementia experience a personality change. They also have executive dysfunction. They have poor impulse control, so they might have excessive eating and drinking. And frontotemporal dementia is atypical because they relatively preserve their memory and their visual spatial skills. In fact, many people that have frontotemporal dementia actually go to psychiatry before they come to us because it doesn't look like the typical dementia that you would see. The natural history and complications of dementia. So with dementia, there is a progressive cognitive and functional decline. There are some non-cognitive symptoms that might be present, such as the psychotic symptoms I was talking about, the hallucinations and delusions. About 20% of people that have dementia experience those. They also might experience depressive symptoms. And the most common symptom is agitation or aggression. It's also the most challenging symptom to address. Unfortunately, statistics say that those diagnosed with Alzheimer's disease live for an average of 9 to 12 years after the onset of symptoms. That being said, we've had patients that come into the clinic that have lived for 15 or 16 years with Alzheimer's disease. So management, let's talk about how we manage the disease, the patient, and the caregiver. And treatment options for managing the disease include medications such as Aricept, Razidine, Exelon, and Namenda. About 10 to 25% of patients improve with these medications. Behavioral symptoms, such as that agitation or aggression, may improve. And it could take a month or more to see any effects, so you might not see immediate change with these medications. There's a lot of inconclusive research out there about things that you can take, supplements that you can take that might help your cognition. You've probably seen some of these on commercials. If you are taking these, or if you are interested in taking these, please let the geriatrician know. We want to make sure that it's not going to interfere with your other medications. And also, a lot of these are actually quite pricey. So we want to make sure that it is going to be beneficial for you before you spend your money on them. In caring for the patient, we promote brain health by exercise, a balanced diet, such as the Mediterranean diet, and stress reduction. We identify and treat other underlying medical and psychiatric conditions, such as the depression or diabetes or sleep apnea. We encourage you to avoid medications that can affect your cognition. And we assess and monitor your psychiatric status. And what I mean by this is that as you are experiencing changes in your cognition, or perhaps you start having hallucinations or delusions or agitation, please let us know. We want to make sure that this is not being caused by your medications. And we also want to make sure that you're not experiencing something such as delirium. In caring for the patient, we aim for the highest level of independence that works for everyone. And when I say everyone, I'm also including the caregivers and the family members in this. As my role of a social worker, a lot of the work that I do is to help and assist the caregivers and family members as much as possible. We also want to talk about your physical environment. So your home, we want to make sure that there's not any fall risks, such as rugs or cords, or maybe a lot of clutter. We might encourage you to install grab bars or a shower bench, shower chair, maybe some ramps. And we also help you managing hot button issues, such as your home situation. Some home situations can be quite chaotic. Maybe you're living with a lot of people and relationships can be stressful. Or maybe you're living alone and you would benefit from somebody being with you more. We also help you with managing things such as driving. So let's talk about driving. First and foremost, I want to emphasize the fact that if you are given a dementia diagnosis in the clinic, the geriatrician is mandated by California law to submit a written report to the Department of Health if a diagnosis of dementia is made. Now, the Department of Health then reports it to the DMV. Most people will need to stop driving at some point. Normal age-related changes can make driving become hazardous, and even mild dementia can impair one's ability to drive safely. So it is ultimately the DMV's decision as to whether or not you can continue to drive. Now you can appeal this decision, and if you decide to do that, please let us know because we want to support you in that process. The DMV will give you some forms that the geriatrician can fill out on your behalf. So we can help you through that whole entire process. Also, too, if you decide that you no longer want to drive, please let us know and we can talk about resources that are available to you for transportation. And supporting the caregiver. So supporting the caregiver, we recognize that they are the most important resource a patient with dementia has. I work with several caregivers as my role as a social worker, and I've noticed that they experience caregiver burnout. Oftentimes, caregivers or family members tend to care for their other person so much that they start to neglect their own health. And about 50% of them can develop depression. So the more knowledgeable and more empowered the caregiver is, the better care the patient will receive. And luckily, there's a lot of caregiver resources that are available. You can go through the Alzheimer's Association, the California Association of Caregiver Resource Centers, and of course, your Kaiser Dementia Care Program team. We will also discuss life care planning for you. We want you to start your medical and financial planning early. And in doing this, you can assign an agent to be your healthcare agent, your power of attorney for healthcare, or your power of attorney for finance. And it's important that you do this because if or when you're ever unable to make your healthcare decisions or manage your finances, then you have somebody there that you trust to help you with that process. We will also discuss the physician's order for life-sustaining treatment, or the POLST form, and this discusses end-of-life care wishes. I try to do this if I have time in the clinic with the patient or the family members, but if we don't have time, we can complete a referral to the life care planning department, and they can help you in completing this form. We remain the patient's advocate as goals of treatment change, and we support family and caregivers when difficult decisions arise. So in conclusion, dementia is a worldwide epidemic, particularly among people that are 85 or older. Many diseases have similar symptoms of dementia, but they are not dementia. History taking and mental status exam are still critical elements of the diagnosis. Physicians can do much more for patients with dementia now than a decade ago. Medications to prevent disease progression and treat complications still limited, but available. Behavioral management and caregiver support are essential. So if you choose to continue with your dementia evaluation, please, as I said before, bring in all your medications, everything you're taking, including the vitamins and supplements, to the appointment. Bring in all the hearing aids and the glasses, even if you're not using them at home. And please submit that pre-visit questionnaire. We are here to support all of you, the patient, the family, and the caregivers, as the disease progresses and difficult decisions arise.